Hello everybody, my name is Loretta Parker and I'm here to talk to you today about sepsis. Let's start with a little bit of general information. So sepsis is the result of an infection that has led to life-threatening damage to the organs. That is sepsis. Septic shock is the result of prolonged sepsis that involves hypoperfusion to the organs due to a drastic decrease in blood pressure. The two most common causes of sepsis are pneumonia and UTIs, which are usually hospital acquired. Some risk factors for sepsis include old age, prolonged hospital stays, immunocompromised status, and some invasive medical devices such as ventilators and IV catheters. So how do we assess for sepsis? The criteria for sepsis consists of what is called SIRS, which stands for a Systemic Inflammatory Response System. The criteria for SIRS is stated as having two or more of the following: a temperature above 38 degrees Celsius or below 36 degrees Celsius, a heart rate greater than 90 beats per minute, a respiratory rate greater than 20 beats per minute, or the white blood cell count that is stated on the screen. It's important to know that sepsis can stem from an infection from any source. While the two most common ones, as I mentioned earlier, are UTI and pneumonia, it doesn't have to be that. It can be from any source and any infection. It's also important to know that the SIRS criteria must be fulfilled to achieve the diagnosis of sepsis, as well as having an established infection to initiate the above symptoms. SIRS plus infection equals sepsis. That is very important to know. So, as I just said, SIRS plus infection equals sepsis. We're going to repeat that a couple more times throughout this PowerPoint. And currently, there is no gold set standard for diagnosing sepsis. There's no one specific laboratory finding, one specific imaging modality. But the SIRS criteria that I mentioned earlier, in combination with the known infection, is considered to be the sort of clinical criteria that's needed to confirm sepsis. Now, septic shock, however, is indicated by a combination of sepsis and other clinical indicators of hypoperfusion, such as hypocalcemia or hypotension, and things like that. So it's important to know sepsis versus septic shock and how one can lead to the other. Now let's go over treatment. So hemodynamic stability is very crucial and has to be achieved through different ways of reperfusion. One way this is done is the 1 hour bundle. This bundle includes the administration of IV saline or lactated ringers or even vasopressors in order to achieve hemodynamic stability. Vasopressin is considered the first-line vasopressor. You can also use epinephrine as well. Also included in the 1 hour bundle are broad-spectrum antibiotics and serum lactate measures that are going to be done periodically for the patient. This bundle must be delivered within the first hour of diagnosis for the best possible outcome, because sepsis can be very deadly. Management of sepsis must prioritize treating the cause of the infection with the proper broad-spectrum antibiotics first, and then you can transition to pathogen-specific antibiotics once you get your blood cultures back. Sometimes you might even need wound debridement or changing out the offending implanted devices to help control the infection, depending on what it's coming from. If it's from a ventilator tube or a Foley catheter, you may need to be aware that those devices may need to be changed out to help control the infection. It's also important to know, should you give your broad-spectrum antibiotics before or after you obtain your blood cultures or wound cultures? It should always be after. You always want to get your cultures first and then administer your antibiotics so that you don't hinder those bacterial infection results of your cultures. Now let's talk about prevention, because we can all help prevent sepsis. So those two most common causes that I mentioned earlier were pneumonia and UTI, which were often hospital acquired, meaning patients developed pneumonia while they were in the hospital or developed their UTI while they were in the hospital. So some ways that we can prevent infection. These can include instructing patients on proper hygiene and wound care, as well as recognizing the signs of infections and when to seek medical treatment. That's more of an outpatient setting way that we can definitely help our patients prevent sepsis, is by stopping that infection up front. In an inpatient setting, however, infection can be prevented first and foremost by diligent hand washing of all medical personnel. This is something we've learned from the recent COVID pandemic, and I hope that it's something that we all continue to carry into our future careers. It's also very pertinent that all catheter devices should be changed in a timely manner based on the device so that we can avoid bacterial growth that could eventually lead to infection. So while PAs may not be the ones changing out Foley catheters, it's still important for us to be aware and to be diligent of when our patients are having these tubes and lines changed out, because they can definitely harbor infection and that can lead to sepsis, which can lead to death. So it's very, very important that we remain diligent in that area. And finally, let's talk about some of the complications of sepsis. These can depend on the source of the infection, but they can include things like kidney failure, tissue necrosis at the site of the infection, DIC, different organ ischemia that can lead to permanent damage. So these are all things to be aware of. And then, of course, there's also death. It's also important to know that certain populations may have a more poor prognosis than others, such as our elderly, those that have certain immunocompromised states and comorbidities such as diabetes, or, as I mentioned earlier, people that are on some restrictive medical device such as a ventilator, or people that might have a permanent, not a permanent, but a long-term catheter, or even like a colostomy bag. So these are all things to be aware of, that these people are more susceptible to sepsis. And as sepsis can involve most organ systems, referrals should be made to their respective specialties as well when that organ system becomes affected if you're in an inpatient setting. So if you're noticing that, maybe you're in an internal medicine clinic or in an internal medicine setting, and you're noticing that your patient is starting to show signs of an AKI, as well as having, an infection from an unknown source, and they're showing those SIRS signs, it's very important that you want to refer to or get a consult for nephrology. And likewise for the other respected organ systems if you are noticing your patient is having damage to those areas. So stay diligent and stay on top of it. It's also good to know that your patient may need to go to an intensive care unit as well to help battle this sepsis and septic shock. So never be afraid to give them a consult as well if you're suspecting this, or possibly even infectious disease, if you believe that this infection could have an atypical growth of bacteria. So just some things to be mindful of. You may be consulting multiple teams and multiple providers. Not one person is usually the one to treat and care for sepsis single-handedly. It is very much a team and collaborative effort. And here are the references that I used for my research and this project. Thank you very much.